And I just want to hand over, I think, next to James Royle, who's a surgeon, who's going to talk to us on Zoom, and then Dean Patterson, cardiologist, also on a Zoom link because they're busy working.
Thank you for the introduction and for inviting me to share my observations and experience with you all today. My name is James Royle. I'm a general and colorectal surgeon working as a consultant in the northeast of England for the past 9 years. I believe the comments that I will make today are true to the best of my knowledge and belief. They are my own personal clinical observations and are not representative of my employer or the NHS. If I could first take us back to when a pandemic was declared, and then in March 2020, lockdowns announced. I was fortunate to be able to continue working, but driving to work on empty roads and then walking along empty hospital corridors were eerie and surreal experiences. To me, our hospital never felt overwhelmed. However, there was a great deal of psychological stress felt by many of my colleagues, mainly driven by the incessant media messaging. I agreed with a personal friend very early on. This was a pandemic of fear. I was not affected this way. I knew my personal risk was very low, and I was happy to catch COVID early if necessary and gain natural robust immunity. Although ICCU expanded its footprint from October 2020 in the so-called first wave, we were able to continue our urgent cancer pathways. All non-cancer planned surgery were cancelled, and we were only able to deliver telephone clinics. We diagnosed at least as many, if not more, colorectal cancers during this period, and we cancelled or deferred very few cases because in my unit, over 95% of cases are performed by keyhole surgery, so patients routinely go back to the ward, not high dependency or intensive care. However, I was perturbed as to where all the general surgery emergencies had gone. The population was dutifully staying away and following the fear messaging to not overwhelm the hospitals and only present when critically ill. In retrospect, I think much of the appendicitis, inflamed gallbladders, and diverticulitis must have been managed in the community with antibiotic teleprescriptions. However, lockdown was a devastating failure, as I hope we all now recognise. At the time, I had been trying to speak up that it was not going to be effective and just cause harm, but was shouted down by even non-medical friends and family who were quickly lockdown experts. The detrimental impact to patients was obvious then. Being isolated and housebound, with incessant, terrifying media messaging generating huge anxiety and fear, leading to social and psychological stress, impairing immune function. The lack of fresh air, sunlight and exercise led to vitamin D deficiency, immunodeficiency, physiological deconditioning and worsening of chronic disease and the metabolic syndrome, obesity, hypertension, insulin resistance, all risk factors for poor outcomes if diagnosed with as COVID-19. It was therefore no surprise to me that my elective cancer mortality rate went from 1 death in my first 5 years as a consultant to 6 mortalities within 30 days, 5 non-COVID, 3 of these sudden cardiac deaths. And then came what they said was our only way out of the pandemic, the coerced, so-called vaccines. Despite the promises that they were only for the so-called vulnerable, sure enough, it progressively became a one-size-fits-all. My red line, when I first spoke up, was to stop it for healthy children. I was sceptical from the start of the rollout of these experimental genetic injections and alert to potential problems. From around March 2021, I started noticing new patterns of disease suddenly frequently appearing that I'd never seen before in my patients. The first pattern was blood clotting, particularly venous thromboses. One of my secretaries asked me, "Why are all our patients coming back with clots?" I was encouraged someone else had noticed. CT scans were coming back, reporting multiple pulmonary thromboses bilaterally, both lungs, clots in the pulmonary arterial vasculature. These were not pulmonary emboli, as thromboses seen in the lung vessels are often called, because they did not usually result from embolization of a DVT, a clot in the leg, in these cases. They were occurring frequently as incidental findings on routine follow-up CT scans in my colorectal cancer follow-up patients. A new triad of spontaneous, unprovoked abdominal venous clots that I had not ever seen before, affecting the same 3 main vessels in multiple patients. Portal vein, from the gut to the liver, superior mesenteric vein, draining the small intestine, and the splenic vein. These patients, typically middle-aged, ranged 31 to 77 years, presented with a vague abdominal pain and no underlying pathology to cause the thromboses, no classical risk factors. e.g. absence of severe pancreatitis or advanced cancer, suddenly happening in multiple patients admitted under general surgery. Sudden increased incidence of ischemic bowel cases, usually uncommon. Many had no visible clots in their mesenteric arterial vessels on CT, as would normally be expected. This could possibly be due to microclotting in multiple small vessels or capillaries, or perhaps from thrombotic endocarditis, as Dr. Dean Patterson has suggested. These thrombotic cases, I'd started testing for the VITS, vaccine-induced thrombotic thrombocytopenic syndrome, that had been defined in some patients after the AstraZeneca vaccine. However, I was seeing these cases after the mRNA, Pfizer and Moderna shots as well. 2 pregnant women presented in quick succession with catastrophic internal bleeding from what turned out to be inflammatory splenic artery pseudoaneurysms. One case I had to take to theatre for a laparotomy and splenectomy. The proposed pathophysiological mechanism of this almost unheard of event, as related to COVID-19 vaccine spike protein, was first described by the late Dr. Arne Burkhardt, a German pathologist. He demonstrated pathological specimens staining for vaccine-induced spike protein present in the vessel endothelium, leading to inflammation and damage to the vessel wall and spontaneous rupture. Spike protein has been found in many organs by Dr. Arne Burkhardt, work now replicated by others such as Dr. Ryan Cole. There was a new, significantly increased incidence of severe, often gangrenous pancreatitis in patients who don't look that ill on presentation, but their initial admission CT scan shows extensive pancreatic necrosis. This is areas of pancreas that have died. This is a new phenomenon. Post-vaccine boosters have observed what seem to be a lot of sudden deaths from necrotizing pancreatitis in elderly patients. One case was associated with more widespread ischemia affecting the stomach and small intestine. This patient had received a 4th booster no less than 2 weeks prior. Spike protein antibodies were over 2,500. The increased incidence of nasty inflammatory or infective emergency general surgery cases, such as gangrenous cholecystitis and gangrenous or perforated appendicitis, especially in middle-aged patients. This is unusual. Also, a notable increase in appendix cancers, considered rare, picked up incidentally on appendicitis specimens. Finally, I need to talk about cancer, particularly colorectal cancers. In addition to the increase in all-cause excess deaths in highly vaccinated countries since the gene-based injectable rollout, there has been observed an alarming and significant increase in cancers. These cancers have been termed colloquially turbo cancers. Obviously, this is not a scientific term, but reflects the different aggressive biological nature that seems to be being observed by the public as well as clinicians. Despite recent articles claiming that the sudden growth in cancers is not new, such as the gaslighting article in the Daily Mail reporting on a baffling increase in trend in data from 1990 to 2019, there is a clear dramatic increase that occurred in 2021, shortly after the rollout. A robust study recently published from Japan, now redacted by the journal after significant pressure, showed cancer-related excess mortality in vaccinated populations. Cancers being observed are in all ages. It is my assertion, shared by many expert oncologists and clinical colleagues around the world, that the cancers we are seeing are extremely aggressive and are of a different biology. One study showed this dramatic increase, particularly in younger ages through 2021, 5.6% increase, 2022, 7.9% increase. I've noticed aggressive widespread recurrences in previously successfully treated bowel cancer cases that I'd considered cured. Many metastases in these cases are unusual or atypical. Middle-aged and elderly people are presenting with out-of-the-blue aggressive stage 4 colorectal cancer who are incurable and die within weeks or months. In many of these cases, the entire liver appears to be filled with large, round tumour masses. It is horrific to see on a weekly basis in my MDT. In my experience, it is rare for colorectal cancer to be as aggressive in elderly. Usually, sporadic cancers that are diagnosed are still operable when they present. Elderly patients rarely present with stage 4 disease, and certainly not in the way I've started seeing. Recently, we've seen 3 patients presenting with synchronous cancers, that is, 2 separate bowel cancers in different areas of the colon presenting at the same time. This was previously considered rare, less than 3%. One was middle-aged, otherwise fit and well, with 2 bulky, locally invasive cancers, and one was very elderly, with 2 primary cancers and liver metastases. Many of my multidisciplinary team colleagues, fellow surgeons, oncologists, pathologists, radiologists, and specialist nurses have all acknowledged to me the sudden change in patterns and dramatic increase in these aggressive, incurable advanced cancers that we've observed in these past 2 years. However, none of them can offer an explanation. Various theories have been suggested. Number 1, inherited or genetic cancer. There is an ever-increasing focus on genetics and cancer. Many of these post-2021 cancers, unsurprisingly, are expressing particular mutations. Despite this, after further analysis at the Regional Genetics Unit, the majority are not found to have any known inherited gene mutations. Aggressive tumor biology will express more mutations. It does not necessarily mean the mutations have caused the cancer. Cancers are also more likely to develop if someone's immune system is damaged or suppressed, as tumor surveillance mechanisms are impaired. Indeed, a recent published study suggests mechanisms of oncogenesis and autoimmunity as a result of mRNA COVID-19 vaccination. Lynch syndrome, HNPCC, hereditary non-polyposis colon cancer, is suggested to cause an estimated mere 3% of colorectal cancer in all ages and 8% among the young. So what then is causing the sudden increased incidence in the other 92% that we're seeing? Number 2, Western ultra-processed diet, obesity, and sedentary lifestyles. Whilst these things have undoubtedly played a major role in the steady increase in cancer over the past 3 to 4 decades, they do not explain the post-2021 sudden increase and change in biology, aggressive nature. This post-2021 increase cannot be explained by a sudden population-wide change in environmental toxins. Ultra-processed foods are not new. We already had an obesity epidemic prior to COVID-19. Number 3, lockdowns causing delayed diagnosis and suspended cancer screening programs. The post-2021 surge in aggressive cancers in all ages cannot be blamed on lockdown and delayed diagnosis. As I showed earlier, during the COVID-19 pandemic, we did not stop our 2-week wait colorectal pathways. We diagnosed and treated more rather than fewer cancers during lockdown as the only pathway that GPs could access. Therefore, this argument of stage migration or missed or delayed diagnosis does not hold true for colorectal cancer. Furthermore, colorectal screening services were only stopped for a few months of the first and second wave. In any case, there is no valid argument that the increase is due to stopping screening, given we are seeing a particular increase in cancers in much younger people, 20 to 45 years of age. Screening services for colorectal cancer and breast and others typically start at 60 years. Number 4, there's a close temporal association of the increase in cancers and the rollout of population-wide mRNA COVID-19 genetic injections. The evident correlation fulfills the majority of the 9 Bradford Hill epidemiological criteria for causation. There are multiple plausible mechanisms that have been proposed by which cancer could be induced or potentiated, accelerated by the mRNA gene injections, including unacceptably high levels of bacterial plasmid contamination, the discovery of the SV40 tumor promoter, disruption of the p53 tumor suppressor, etc. These mechanisms are discussed widely by scientists and clinicians, such as Dr. Kevin McKernan, Professor Angus Dalgleish, Dr. William Mackis, and Dr. Ryan Cole, a US pathologist, and many others, and have been discussed on numerous international calls. More generally, the shots are clearly causing generalized immunosuppression. The immune system is grossly underestimated in its complexity and importance in tumor surveillance, in destroying mutated cells before they become cancers. Recently, other doctors have told me how they are seeing sudden recurrences of cancers that have been cured 10 or even 15 years earlier. I submitted over 20 yellow cards from June 2021. I could have submitted many more, but it was becoming very apparent that the MHRA was ignoring the data. I've never been given any feedback on any analysis of my cases, or even acknowledgement, except for 2 or 3 cases where further clarifying information that I had already provided was requested. I was given no information back from the MHRA to indicate that they were looking at yellow card data or analysing it. Despite this, the safety signal from both the MHRA and the VAERS system in the United States is unprecedented and undeniably obvious. Presenting this information formally, I've received mixed responses. More recently, in my more departmental morbidity and mortality meetings, there has been a more open acknowledgement that perhaps some observed events, such as ischemic bowel cases, may have been related to the vaccines. I've had a number of conversations with 2 colorectal colleagues in other areas of the country who have had similar shared experiences and are in agreement with the observed patterns of thrombotic, infective and inflammatory, and malignant disease. I've had the opportunity to give a presentation to an international surgical meeting in London in March 2023. At the end, I was congratulated on my perceived courage in standing up and speaking about these concerns. There was general agreement in the room, 30 or more surgeons. Many offered acknowledgement and similar observations, but had been unwilling to raise their concerns for fear of repercussions. In fact, a rather alarmed, eminent retired surgeon present stated it was our duty to raise these concerns. In conclusion, the data are clear that COVID-19 vaccines are neither effective or safe. My own personal observations have been increasingly backed up by other data around the world and research studies, as well as expert opinion in other centres. I personally demand that these injections and any promotion of them be stopped with immediate effect. Thank you for your attention.